My name is Charles Taunt. I'm in Lansing, Michigan, where I've practiced primarily adult hip and knee reconstruction for the past 19 years. Prior to that, I was Dr. Henry Finn's fellow at the University of Chicago. My practice focuses on adult hip and knee reconstruction, primarily related to arthroplasty, and have a pretty involved revision arthroplasty practice in both the hip and the knee.
Do you consider potential metal sensitization an important issue to discuss pre- or post-operatively with your patients?
I think metal sensitization is an important topic to discuss with patients preoperatively if they have an obvious historical metal sensitivity or concern about it. Certainly take patient concerns about metal sensitivity seriously, and if the patient is serious enough about their concerns, then I'll refer them for LTT testing so that we really have data by which to make a decision. In some instances, we use implants that are low or minimal nickel, with the thought being that the most common sensitivity is nickel, and oftentimes that reassures the patient. And then I think another scenario is the patient who is not satisfied with the outcomes of a surgery that they seemingly should be satisfied with. And so in those cases, we'll first rule out all other kinds of sources of pain. This is usually in their total knee, component loosening, malposition, instability, infection, hip disease. If all of those things seem to check out as being good or not a source of the patient's pain, then oftentimes, again, we'll refer them to see if by chance they indeed have a metal sensitivity.
How has Orthopedic Analysis metal-LTT testing helped patient outcomes in your practice?
Orthopedic Analysis LTT testing has definitely helped patients in my practice. We have identified a fair number of patients over time who are dissatisfied with a otherwise seemingly well-functioning, usually knee replacement, and have been able to revise that to an implant that better suits their allergy profile, if you will, with very good success. We published one paper on that, which actually the results of were fairly surprising. The most surprising result was the very rapid statistical significance in the reduction in patient self-reported pain after their revision surgery. At 6 weeks, there was a very highly statistically significant reduction in patient-reported pain and improvement of function after a revision surgery when the patient had implant with a metal in it that they were sensitive to based on orthopedic analysis testing.
Which patients should consider metal sensitivity testing?
So preoperatively, I think the patient who should pursue LTT testing is one who believes that they have a number of sensitivities to metals, or one who can't pinpoint what they believe they're sensitive to at all. The patient who says, I'm really concerned and I'm sensitive to all metal. That's highly unlikely to be the case, but I don't know where to take that clinically. And so subsequently, I think that those patients that have that element of concern should get tested preoperatively. In the postoperative setting, I think the patient who is dissatisfied with a joint replacement that seemingly they should otherwise be satisfied with, that other mechanical and infectious causes of failure or dissatisfaction have been ruled out, that those patients at least should have a discussion about metal sensitivity testing and pursue it if they think that they would be willing to act